Welcome, everyone. It's about 12:01 now, so I think we're going to start to get rolling. And thanks to everybody who joined early today. So we're very excited to be kicking off this series. This is our main educational series for this study and project on advancing hospital-based opioid treatment, or HBOT. I met sort of remotely many of you through the kickoff meetings that we had. I'm Jennifer McNeely. I'm the NYU principal investigator for the study, and we have other members of our team here today that I'll introduce shortly. But a couple of things before we get started. The first is really exciting that we have CME credits available for each of these lectures if you attend the live session like you're doing now. So huge thanks to Northwell for providing this. It's a real benefit and a boon for all of us. So thank you. And we're going to give more information at the end of the lecture about how to actually claim those credits. So this is the first of our 7-session series. All of them are scheduled sort of every other week at this time. So hopefully you have those in your calendar, and there will be CME available for all the others as well. A couple of housekeeping things before we launch in are, as you saw, Adetayo, who's our research assistant, is with us, and he had asked everyone to put your name and email into the chat so that we'll be able to follow up with people afterwards. So please continue to do that. Adetayo, any other instructions for right now at the beginning?
No, that's about it. Information on CME will come towards the end of the session. Thank you.
Great. Please keep yourselves muted while we're talking, just to reduce background noise. But if you have questions or as we go, we totally encourage you to put those into the chat while we're presenting, and we will aim to cover those at least at the end, or possibly in the middle, especially if it's something that needs clarification. Noah Krawczyk is the co-I for NYU on this study. She's going to be monitoring and moderating all of that. Noah, anything to add there?
No, that sounds great. Yeah, and I think if people have questions throughout, we do have some time for discussion. So just feel free to type it in the chat, and I can moderate it. Or if we have some time, folks can even take themselves off of mute and ask directly. But we can see how it goes throughout the talk.
Sounds good. And then I'm going to introduce Shane Gallagher, who is going to be the main presenter today. Shane, some of you met during our kickoffs, but he is a psychiatric nurse practitioner who, among other things, was one of the key providers for the launch and continuation of the Bellevue Hospital Addiction Consult Program. So Shane comes with a lot of clinical experience as well as practice change experience, and we are very excited to have him working with us and working with all of you. I turn it over to you, Shane.
Thank you, Jennifer. So I'm glad to be here. As Jennifer said, my name is Shane Gallagher. I'm one of the co-investigators at the NYU team, and I'll be the lead practice facilitator, so providing technical assistance and meeting with the hospital. So I'm looking forward to that. Hope you enjoy my lovely mountainous background view and foliage here. I have no financial disclosures or conflicts of interest to report. So just to reiterate, I think we just said, if you could please type your name, facility, and role in the chat box. This is how we're going to note attendance, and then we're going to send out the slide deck to those who put their emails into the box. I know it's lunchtime, so if you're chewing and drinking, that's fine. If you could please try to turn on your video when you can. We would love to see faces, a bit more engaging, see folks who are here. When you're not speaking, please keep your mic on mute. And then, okay, this is redundant. Yes, name, facility, role. We would like folks to share kind of case examples, but no kind of in-depth PHI, please. No stupid questions. We're all figuring this out together. And we'd like this to be as interactive as possible. This initial introductory lecture contains a bit of epidemiology data and kind of some larger big picture overview. And throughout the lecture, there will be prompts for folks to participate. It would really be more kind of instructive and helpful if folks chimed in. So please feel free to speak up, or if you want to put some examples into the chat as well, that would be great. So to give you an overview of the topics we're going to cover the need, and we're going to look at some perspectives from patient, provider, and the healthcare system at large. Then we're going to do some review of the evidence regarding medication for opiate use disorder as an evidence-based practice strategy, and then some outcomes from hospital-based addiction consult service, which is one of the strategies used to implement HBOT, or hospital-based opioid treatment. So for those of you who haven't heard HBOT, we'll use that acronym over time to refer to this model, which takes us to the next point, kind of the impetus for change. So we'll define the HBOT model and some implementation techniques that have been used in the past, charting a path forward, and talk about some of kind of the seminal pieces in guiding organizational change. So starting with the need, so many reasons drive the need for us to address opioid use disorder as part of hospital care. As our first prompt, it says to type in the chat, or folks can feel free to chime in. Why do you think it's important to address opiate use disorder as part of hospital care, inpatient hospital care? Any brave souls?
Can be anything really basic. It doesn't have to be a very prolonged answer. Okay, great.
Oh,
We're
I see.
seeing some chats come in.
So pain management may be affected by existing OUD. Yes, very much so. So often folks will have comorbid pain issues, and that can be kind of like how clinicians will decide to prescribe and manage pain. Certainly is influenced by stigma or understanding of opiate MAT as well. High variability in how it's done, that's a great point. We'll cover that, appreciate that point. Purposes of public health efforts, absolutely. We'll talk about some of the local and national trends coming up. Oh, this is a good one. Patient shows up for other issue.
No, where did my toolbar go?
So we'll definitely talk about how when patients are admitted to medicine or surgery, sometimes there's a very problem-focused orientation to addressing kind of the chief reason for admission. And it could be a great opportunity to address the opiate use disorder, and sometimes it's overlooked. Oh, this is a great one, actually. Why would we miss an opportunity to save a life? That's great. I really like that one. All right, so thanks a lot for the input. I appreciate it. So our nation's facing a crisis, pretty hard to miss in the media. As of 2015, overdoses have exceeded annual deaths at the peak of the HIV/AIDS epidemic in 1995. So in terms of clinical zeitgeist, this is really one of the major public health crises facing our nation. As of 2016, overdoses killed more Americans than the entire Vietnam War, and I'm sure folks have seen the data trends were not um, didn't look great from last year in light of the COVID pandemic. Overdose deaths were just shy of 100,000. So more than ever, we really need systems response both on the national level and at the local and hospital level. And so here's kind of an overview from the CDC of the surging overdose deaths involving specifically synthetic opioids into the drug supply. So you can see that orange line there in the mid 2010s when synthetic opioids, other than methadone, primarily fentanyl and other formulations of fentanyl were introduced. This really caused a major rise, more than double the overdose deaths rate. So definitely something and with that, we can see there was a rise in opioid-related hospitalizations. So we can see as a rate per 100,000 claims from 1998 to 2006, we have another exponential rise of 3 time increase in the rate there. And then a review from JAMA in 2021 shows that substance use disorder, especially opiate use, drives high rates of hospitalizations, increases length of stay, leads to frequent readmissions, with over $13 billion in spending in 2017. And then despite the knowledge of frequent and costly utilization of acute care, it's quite infrequent that patients are engaged in SUD treatment while in hospital or afterwards. Folks with opiate use disorder have high rates of comorbid chronic illness, high utilization and hospitalizations in ER and readmission. And so, as someone pointed out, there are folks who are frequently admitted with medical complications of SUD. So, for example, infectious endocarditis or osteomyelitis secondary to injection drug use, or folks may be admitted for seizures in the setting of comorbid alcohol use. And this the research has shown that many are not engaged in addiction treatment at the time of discharge and aren't leaving the hospital with an appointment or an opportunity to follow up. And as we know, effective treatments exist, are largely underutilized. So medications like naltrexone for alcohol use disorder or methadone or buprenorphine for opiate use disorder. This is partially has been found to be due to a need for provider education and increased comfort, and as well as some treatments such as buprenorphine and methadone require integration across inpatient and outpatient systems that are traditionally siloed. Hospitals have been slow to respond. So again, we've talked about hospitalization will often address acute medical needs, but not some of the underlying causes that are driving these readmissions. And a review in the Journal of Internal Medicine showed that most hospitals don't offer medication or MAT for opiate use disorder. And we know the sequela of this leads to untreated opiate withdrawal. Patients avoid or leave the hospital against medical advice. And as somebody said before, it's a missed opportunity to offer life-saving treatment. So from the patient perspective, most patients with high-risk drug use are interested in cutting back or quitting. It's been found that many want to start or continue medication or MAT while in the hospital. But because of transitions of care, there's often care fragmentation or gap times in community treatment. And this can be a significant barrier in engaging folks after discharge. And patients want choices of treatment options and providers that understand substance use disorder. A big part of this is a kind of non-judgmental and destigmatizing approach. And here there's a quote from a patient. Most of us that do it can't stand it. I hate the stuff. It's wretched. It's like damned if you do, damned if you don't. When I do it, I don't even feel good anymore. Like it takes so much just to be okay to be normal. It's like when I use, I just feel normal, so they don't understand that. And for those of you who work inpatient, this is a common scenario that I've definitely seen where the clinical team will kind of misunderstand if a patient, say, is on a maintenance dose of methadone 80 milligrams. They're likely to undertreat pain because there is this illusory belief that methadone, since it's a strong opiate agonist, is going to be providing pain relief, when in reality, it's just preventing withdrawal. And since folks' opiate receptors are upregulated and saturated, they're really going to need more aggressive pain management. With that comes the fear of either worsening or perpetuating an addiction, and you'll hear stigmatizing language used like med seeking or needy or malingering used with these patients who indeed um, have real pain and need it treated in a more aggressive fashion. So missed opportunities from the perspective of the provider. Quickly look at findings from a study of hospital care before and after an addiction medicine consult service was implemented. So before addiction care, a patient advocate noted that providers get called to the unit because the person is yelling or throwing things or appears impaired. It often blows up and they get discharged or they leave against medical advice. We don't really know what happened to them, and they're vulnerable, and staff are vulnerable, and other patients are distressed by disruption and commotion. So I think what's important to note here is patients are vulnerable, but there are certainly dynamics where other patients in the hospital and staff also feel vulnerable. This can be a difficult process. Folks who are in acute opiate withdrawal, it can be a very agonizing experience and lead to behavioral disturbance or wanting to leave the hospital if they're being undertreated. And so, a quote from a hospitalist in this study: you would see this pattern, especially in the IV drug using population. Left AMA, left AMA, left AMA. 9 times out of 10, nobody was dealing with the fact that they were going into withdrawal. From a nurse manager: caring for people with substance use disorder was very emotionally draining and very time consuming.
Yeah.
So I'd like to open it up again. What challenges like these have you observed at your hospital? You could have representatives from the different hospitals. Anyone want to jump in? Maybe from one of the Northwell sites, what have you guys seen? I said all of them. So we have increased staff stress. So certainly frequent readmissions in AMAs, increased length of stay. Poor patient outcomes, definitely. Difficult patients, I see. Labor intensive and time consuming. So that is something to keep in mind. It really does take a team approach because it can be, um, a time-consuming process treating in the hospital, and then it can be a complex referral and connection to aftercare, especially if folks aren't familiar with what community resources are available. Any other thoughts on hospital challenges to providing OUD care? I see another comment in the chat. For post-operative pain, it's difficult to explain to the patient. It may be difficult to treat their pain, and they have to be patient with us. So certainly, and I think that really can be different across contexts for teams that are used to treating this population and really kind of understanding. An example, I'm sure many of you have seen, the decision whether to continue or discontinue buprenorphine in the perioperative setting, there's kind of different opinions on this that aren't always evidence-based, because it is advisable to continue it in the perioperative setting, but sometimes folks will discontinue it. And I've seen the scenario where if a team or surgical group isn't comfortable or as familiar with the medication, they're not as likely to start it or make sure that the patient is connected when they're being discharged. Another comment: attendings aren't aware that it's relatively easy now to provide or prescribe Suboxone compared to before. That's a great point. I'm really glad you brought that up. The requirements for the X waiver have been reduced now, so that the class isn't required. So there's less barriers. While it still is advisable to get training and use the or there's less of a kind of administrative burden for folks to be X waivered, and this can be done on a kind of larger hospital level, working with the pharmacy. And then finally, I see long-term solutions and partnerships with available resources after discharge. So for those of you who are connected to kind of outpatient clinics in like a larger academic medical setting, that can really be a large impact. Thank you again for all those great insights. And so let's look at some of the evidence. What are some ways that we can address this need? So the main offerings for opiate medication-assisted treatment, or MAT, are methadone and buprenorphine. So we know methadone is a full opiate agonist, and buprenorphine is a partial agonist. They're used to treat acute withdrawal. We've been talking some about this. They can improve pain control and setting of withdrawal and pain. They're used to reduce opioid cravings. They allow and help facilitate patients to tolerate and engage in medical care with more regularity. And they can be started in hospital and continued after discharge. And this really leverages an important reachable moment while they're admitted to the hospital. So medication is a key part of treatment. A Nelson Cochrane review shown that when folks are on methadone and buprenorphine maintenance, it decreases their overall drug use. It decreases rates of HIV and hepatitis C infection. It decreases their interactions with the criminal justice system, decreases overall mortality and morbidity. And it helps support folks to enhance quality of life and reduce some psychosocial stressors, so be able to return to work, engage in healthy relationships, and be effective parents. And so here is some data drawn from, we can see the PCSS. This is a great tool, if you're not familiar with it, the Provider Clinical Support System. And it shows the standardized mortality ratio. When folks are on some form of medication to treatment, it lowers the mortality ratio almost to that of the general population. So we can see that, as someone highlighted before, this really is a life-saving intervention. So if we're not offering folks this medication, they really are at a majorly increased risk for morbidity and mortality. And so something to keep in mind after folks, so if folks are coming in the department or for an overdose, so if that's the reason for admission, compared with no MOUD, if the folks were started on methadone, it's associated with a decreased all-cause mortality, as well as a decreased opioid mortality. And buprenorphine or Suboxone was associated as well with a decreased all-cause and opiate-related mortality. And so MOUD is associated with larger mortality reduction than, and this is a pretty sobering thought, any antihypertensive, diabetic agent or statins, and more than aspirin after a STEMI. So, these kind of tried and true gold standard treatments that we think about, that we provide algorithmically, kind of without thinking, if somebody has a STEMI, it's indicated. We use a MONA protocol. We wouldn't think twice about it. It's really important to think about reframing and structuring hospital-based care as these medications, if a patient has opiate use disorder, should be the standard of care. There should be no reason why folks aren't offered these medications. So some outcomes here, we can see there's kind of a robust body of literature. Um, Impact is a rigorously studied model of addiction consult service in the US. And to date, these consultation services for patients with OUD has been showed to decrease post-discharge substance use, decrease the severity of the substance use disorder, increase post-discharge engagement treatment for opiate use, increase trust in physicians and the healthcare system, and broadly improve hospital settings that care for people who use drugs. It's interesting and important to note that a lot of the research to date about the impact of these services has been conducted on the West Coast. There are some kind of in recent years, including in New York, that are replicating this model. But something that's important to note here, especially it's been a really difficult time for healthcare providers in the past couple of years with the pandemic. One of the studies, the Journal of Hospital Medicine, providers noted that it alleviated moral distress. So a lot of the comments in the chat about really complex and difficult patients, offering these medications give folks this sense of kind of efficacy and alleviated moral distress. And it also supports hospitals to be more trauma informed and patient centered care. So hospital-based addiction care, again, alleviates widespread moral distress. Hospitalists noted, I don't know if it gives them a voice or allows us to hear them better, but something's happening with communication. So again, this kind of maps onto kind of across, it's really not just physicians and nurses, it's really kind of across the care spectrum, kind of reinforcing the culture of talking about this, doing a good substance use assessment on inpatients, and then allowing them to feel heard in a non-stigmatized, non-punitive fashion. Perspective from a nurse here, I think you feel more empowered when you've got the right medication, the knowledge, and you feel like you have the resources. You actually feel like you're making a difference. And hospital-based addiction care completely reframes addiction as a medical condition that actually has a treatment, or actually multiple treatments available. So we discussed about how this is a major problem affecting the healthcare system, and there are tools to address it. So now we'll talk about the how. So as we've been kind of saying, if folks are hyperglycemic, we would certainly talk about dietary changes. We would provide treatment with insulin. After an NSTEMI, we would provide aspirin or provide a statin if they have high cholesterol. But for some reason, there's sometimes a stigma around since it's sometimes considered a behavioral element more than a medical condition, that we don't have as much engagement, or there's not as much comfort talking about substance use. And as we've noted, most hospitals don't offer MAT for withdrawal, and most hospitals aren't offering naloxone or Narcan rescue kits, a medication that can reduce or reverse an overdose. And as well, we talked about how most patients are leaving the hospital without a linkage to aftercare. And so these are kind of some of the key targets that we want. We want medication to be offered for withdrawal management and then discharged with maintenance. We want some harm reduction interventions, including a naloxone kit, and then engage and link them to aftercare. And so these are kind of the key components of the HBOT or HBOT, hospital-based opioid treatment model. And so with that comes routine assessment, so identifying and diagnosing opioid use disorder in patients, and then offering them an MAT option, and then provide naloxone and offer guidance. And quite a few hospitals throughout New York get the kits provided through what's called OOPPs or opioid overdose prevention programs. So if that is not something that's part of your hospital, that could be something that's explored in pharmacy at your site to kind of streamline a way so that patients can leave the hospital with an naloxone kit. And so there should be a multifaceted approach to change. So a big one a big barrier that's been identified is lack of provider education and comfort. Um, is it always being reflected and measured in the data, and then implement policies to address those? And then engaging leadership to facilitate practice change. And a thing here that we've included from the studies is including perspectives and the voices of the patients. That can be a really kind of impactful, humanizing, and meaningful tool for gaining buy-in across different stakeholder groups. And then making good community partnerships so that the treatment pathways implemented while admitted can be linked to aftercare. And so something that's been reflected in the literature largely, especially by folks at the UPenn group, is the impact of stigma. So a lot of the attitudes of providers and language that's used, patients find stigmatizing, and it makes it difficult and a barrier to kind of access and engage with the healthcare system for treatment. So there can be multiple pathways to change. One can be an internal, engaging hospital administration, and then external stakeholders. So state Medicaid programs, or as I was mentioning, OOPPs, or um, federal resources coming out now for harm reduction, such as like fentanyl testing kits and so forth. Um, Existing addiction-related strengths and resources that exist in the hospital, and having those feel less siloed and more connected across different teams. And then connecting to community-based treatment programs. So OTPs, or opioid treatment programs, previously used to be known as methadone clinics or methadone maintenance treatment programs. Now many of them offer Suboxone as well. So having good relationships and kind of seamless referrals and warm handoffs with them. Uh, Something that can be a barrier are restrictive and misinterpreted opiate agonist therapy policies. So folks feeling uncomfortable, or pharmacies being reluctant to approve a methadone taper, or having restrictive practices around, while inpatient, only allowing X-waivered physicians or APPs to prescribe, when in reality, the hospital's DEA in New York State will cover um, providers to write buprenorphine while inpatient. They would need to be X-waivered in order to write a discharge prescription, but they're able to manage withdrawal and initiate maintenance treatment while in the hospital. And then, again, as part of cultural change, ways in which stigma and discrimination towards this population come into play. So another question, what do you think is a challenge at your hospital or system that you may face in implementing an HBOT model? Folks who are kind of treat this population or see patients with opiate use disorder. Yeah, Adam, I see a hand raised.
Well, this is kind of, I guess, future oriented, but it would be great if hospitals could, in addition to starting Suboxone, if they're afterwards, as they're about to be discharged, give them like a Sublocade, the injectable buprenorphine injection, because that would give you, it's in your system for, can be in your system for months, and it gives you a very nice window if you can't get an immediate appointment and you're like, do I want to give this guy 2 weeks? Do I want to give this guy 2 months? How about giving him a shot and then follow up within the month? And if they could, if the hospital could get it through the inpatient pharmacy benefits, I'm hoping to see that in the years to come.
Yeah, no, I'm glad you brought up the long-acting injectable formulations because I think it's as of this year in 2022, the state Medicaid formulary expanded, so it's reducing barriers to providing those treatments that you're mentioning, like it's branded as Sublocade or the long-acting. If a patient was interested in long-acting naltrexone or Vivitrol, I know on the service I worked on, sometimes patients were interested in that if they were more motivated for abstinence based, they would get an injection or discharge. And since the extended release bupe, it can be initiated in a weekly formulation. So like you're saying, Adam, it could be a great mechanism to bridge patients until they can get that first appointment.
We use with Sublocade, at least outpatient, ChemRx. For patients who have Medicaid, ChemRx they're phenomenal. We use some in some cases like next day delivery of the Sublocade, so they're a great resource as opposed to some of the other ones like a Credo that can be a lot more complicated.
Thank you. Any other challenges that folks foresee in a hospital system to implementing a hospital-based opiate treatment model? All right, we'll keep it moving. Here are some examples of kind of like thematic groups of challenges. One is no prescribers, and by that, as we just kind of alluded to in the last slides, this is more of the comfort and folks being willing to, because there are if people have the ability and they can prescribe, it's more of prescriber comfort and familiarity. And so to that end, if hospitalists don't feel comfortable prescribing buprenorphine, for example, and have a very structured methadone taper, you can have it in a scenario where the patient is off opioids with no discharge with no maintenance, which, as I'm sure a lot of you know, put the patients at elevated risk. There's kind of the twofold risk factor. One being patients after an admission, especially for overdose, are at elevated risk, and patients who taper off and have a lower opiate tolerance are also at elevated risk. So that can honestly be doing a lot of potential harm or elevating the risk profile for a patient discharged after a methadone taper with no bridge to maintenance. And so there's an example, say there's a hospitalist service where very few have buprenorphine waiver trainings or familiarity with the medication. But an idea could be creating an order set or a treatment pathway that makes it easier for colleagues to provide buprenorphine. In this particular study across the different hospitals, we're having a champion that's situated to help engage more stakeholder groups across the care continuum. So it's often a good place to start with hospitalist or medicine services, but also engaging surgery, psychiatry, social work, nursing, pharmacy, and establishing real-time phone support. There are online resources, but also sometimes it can help to have kind of an internal a champion or someone that can be reached out to in order to provide guidance. Barriers to methadone. So we've alluded to pharmacy having more restrictive practices around approving methadone, worried about the legality since methadone can't be prescribed outside of an OTP other than, say, for a palliative care service for chronic cancer pain. There's likelihood that pharmacy will not want to approve those orders for methadone. And so some examples of solutions have been clinical leaders borrowing a methadone taper policy from a regional hospital with robust consultation services, reviewing with pharmacists, and then adopting a similar policy, and also engaging and providing pharmacy training, opportunity to address any questions and concerns. And then a lack of referral services. Hospitalists or clinicians not wanting to start buprenorphine because of a lack of either awareness or referrals to community providers in the area. So a start could be meeting with a regional Medicaid organization and identifying the problem, and then linking to community providers, making introductions. And then the hospital community partners creating clear pathways and so that efficient referrals can be made.
And Shane,
And
there
so
was
in the
just a comment on the chat from Gary Schwartz that you can also prescribe for chronic pain as long as it's stated on the prescription.
Yes, and I would be interested to hear experiences from other folks. I know in the hospitals that I've worked in, medicine teams are usually reluctant if the patient has opioid use disorder without kind of a chronic pain syndrome or cancer diagnosis. They're reluctant, and rightfully so, to want to prescribe the patient methadone. But to that end, like I said, you often will leave patients in the scenario where they have no form of maintenance, and it's often a challenge is opioid treatment programs, or OTPs, often won't set up an appointment. They'll have walk-in hours. So, a kind of gap in care that I definitely see is a lot of OTPs are closed on Sunday. So you run into the issue, if you want to discharge a patient on Friday or Saturday, if they can't make an intake by 7 or 8 a.m., which is a lot of the walk-in times, they can be left in this scenario where they don't have any kind of tools to rely on, and it could potentially trigger a relapse or lead them to want to use. So in the CTN manual, the HBOT manual that we're providing, we're going to be going over these in the coming weeks. Different topics, one being tools to diagnose an accurate diagnosis of opiate use disorder versus risky opioid use, and then some medication protocols and how to initiate folks on MOUD. Also, some strategies for getting leadership buy-in and forging community partnerships. And we're going to discuss some harm reduction tools, because when a patient expresses that they're not ready to stop using, that doesn't mean that there's not an opportunity to engage them. In my team's practice, it was definitely a common practice as part of our assessment to engage the patient. So asking them what is the drug doing for them and how they're using. And you can get a lot of information from that. They can walk you through if they're obtaining clean needles, and if not, where they can obtain needles. And you can give them some basic kind of etiquette for overdose prevention and reduction. So to go to a needle exchange or harm reduction center, to not use alone, to test their supply for fentanyl. So there's going to be a lot of opportunities to engage those patients. And I've found that this kind of non-judgmental approach, talking very kind of frankly and openly, helps the patients trust their team more and want to engage, and more likely to accept that referral or continue on a treatment. But at least if the conversation is being regularly brought up with patients who are admitted, they know that it's available to them. They can kind of jump on the train when they're ready. So this is kind of the conclusion. One more. There's another discussion question. What are some ways to increase leadership buy-in for supporting HBOT? Has anyone had success or barriers in mobilizing leadership on a larger stakeholder level? or any efforts you've seen to try to start increasing or engaging HBOT at your hospitals?
Or kind of in the opposite, if anyone has had kind of challenges, particularly around buy-in for supporting HBOT, we're happy to hear those as well.
I see anything with a spreadsheet that shows how money is saved usually goes over well. And along that vein, I see also addressing reimbursement issues for inpatient. So yeah, no, those are great. There's certainly, as we went over before, like a robust body of evidence, not only on a national but on a local level of the cost savings. So it's um, definitely easy to develop a business case for why this would be productive to um, a leadership team to engage with. So that's something that in technical assistance and practice facilitation we'll talk about how to develop a business case for leadership. So addressing some of the core values or mission of your organization can be a way to start. Talk with other successful colleagues, not only related to addiction treatment. It can also be other folks who have successfully launched QA projects, especially in the inpatient setting. What have been some effective communication and education strategies for launching a program like this? And something that's important is engage key stakeholders, not only at the top, but across different disciplines. With HBOT in particular, it really is important to have providers and nurses who are providing the frontline care involved, but also social work and case management who are going to be linking to aftercare, pharmacy who can help streamline the process for getting medications approved um, and verified also. And then review the strategic plan for your hospital and see how linking HBOT can be linked to strategic goals. Quite a few folks have mentioned length of stay and readmission, so those are some kind of low-hanging fruit that are always in the minds of hospital medicine services. So that can be a way to discuss the cause of improved outcomes. Also, staff satisfaction and surgical outcomes as well.
Thank you.
Then on the flip side, considering the way the current system is failing or organizational barriers, we've talked quite a bit about using patient narratives or case studies. Providers who work with this population have a unique insight into how the care can be better and outcomes can be better for these folks. Emphasize opportunities to improve cost and care quality, and then combine local examples on what is known from literature and expertise of our hub. And so in the initial steps of developing these goals, it's really important to think about the 3 M's: measurable, meaningful, and manageable. And there's this model called a SMART goal. So you want it to be specific. So state exactly based on the reality is in your particular hospital, you may not have a great idea of what the baseline is. So that can be one of the initial goals, is to get a specific metric that you want to be measurable. And, if your rate of engagement, say, is 20 or 30%, you want to make it something that you can actually achieve. You don't, it would be great from a quality care perspective to have 90 to 100%, but maybe not make that jump. Maybe make small interval changes. Again, with that being realistic, based on resources in the hospital, and then timely. So we'll implement PDSA or Plan, Do, Study, Act cycle. So we'll see within a short benchmark interval what is and is not working and how we can kind of tweak that to meet a larger long-term goal. And so we want the data collection to be as streamlined as possible, especially if folks have data collection capacity in their EMRs. It can be helpful to kind of operationalize based on variables that your organization is already collecting. And then you definitely want to report successes. So you want to celebrate those small victories in the beginning as you're kind of moving towards progress there. And then some other pearls. You want to hardwire some space for interdisciplinary communication. So that can be kind of a challenge across departmental. If other consult services don't have a good kind of bridge of communication to medicine, that can be one of the initial steps there. And then start where you're most likely to be successful. So if you have kind of a residency program where they're interested in kind of ongoing education and learning about this, that can be kind of a good initial group to engage as kind of ambassadors to different primary teams. So in summary, critical that we address opiate use disorder in hospitals, a treatable chronic condition as part of hospital care. Defining it, we can define the need from patients, providers, and larger health systems. We do have a robust body of evidence that supports MOUD being a life-saving intervention, and that embedding different models of addiction care in hospitals, we can increase engagement, reduce morbidity and mortality, and improve care outcomes. But change does require multifaceted across micro and macro system strategies, and considering broad stakeholder perspectives. So before, we'll have a question and comment time, but quickly before, I'm just going to pass it over to Noah just to talk about the survey information.
Thanks. So just really briefly, we did talk about this a little bit in the kickoff meeting. We are offering this survey that's part of our study. It says 25 minutes, but it really takes about 15 minutes to complete, and you'll receive a gift card if you do complete it. So we do encourage everybody who attended this session or the kickoff to participate. You can only do it once, so please don't try and do it again if you already have, but if you have completed it and have not yet received your payment, please email us at this email below. We want to make sure that we get your payment over to you. And if you go to the next slide, Shane, there's actually a very easy way to just go to the survey if you want to complete it now or after the session that you'll receive the slides. You could just use this QR code depending on what hospital you work at. So it should be pretty straightforward. And I'll just make a last plug-in to please, if you haven't already, just put your name, your affiliation, and your email in the chat box. We're going to use this to actually email this out to you at the end of the session so you can get the links to the survey and also have this information for future reference. So please do add that to the chat before we jump off the call. I'm happy to answer any questions about that as well.
And just noting that in the chat, Aditya put the link, so if it's easier for you to click on a link to start the survey instead of doing the QR code, that's in the chat now.
Great, thanks. So we can also now, we have a few minutes for questions related to any of the material today. Or comments, ideas. And for those of you interested in CME credits, the information should also be pasted, I believe, in the chat. Aditya will be adding that in as well. So you'll be able to access that. And that will be available only to people who have actually attended the session live. So yeah, please, if you don't get that information, you'll also receive it in the email follow-up.
I want to thank you, Shane, for presenting today, and thanks to everybody for joining. I think we have 4 minutes left, so it feels like we can't start another sort of larger discussion, even though I'm tempted to do that. But if folks want to throw out any thoughts, including about things that you think would be helpful for you to advance this work at your hospital, or questions about what Shane presented, or questions about how to do the survey or the CME, just feel free to unmute or put it in the chat. We'll stick around. And maybe, Aditayo, could we go back to the slide with the QR codes on it in case people want to do that? Yeah, while we're waiting.
There is a comment from Javier Jimenez that just to emphasize that the desire for dedicated addiction consult services to specialize in this complexity is great. And it's very tempting to just have those experts available to do this.
That is a great, comment, and I think an important distinction to point out here is that, there are Cadillac models of addiction consult services where you have, a dedicated team to do this work, and that tends to be sort of the imprint on our minds for how you do it. But there are also a lot of other models, hospitals with experience doing HBOT, where it's, a champion or a team of hospitalists, or the psych CL service, or other non-dedicated addiction providers who just build up some expertise and spread the word that they're there to help. You put in some order sets and you can actually accomplish a lot, just pulling on the resources that you have in the hospital. And I think some of our facilitation work and some of these next presentations will talk about a bit more like strategies for how to do that. But I think if you can convince your hospital to get you a consult service, it's great to have one. I think it's the experience of all the people who work in hospitals that have them. But you can do a lot without that also. That's a great comment. And just to stay on my soapbox for a minute more, I think, I'm an internal medicine doctor, and when I was in residency, I did not call cardiology for every patient who came in, with a poorly controlled hypertension. I was confident managing that on my own. It was part of my scope of practice. It was a common condition, and I knew how to use medications to to do exactly the same thing they would have done. And I think that for opioid use disorder in particular, with other substance use disorders, it can be more complicated. But with opioid use disorder, the medications are so effective and safe that we really should be able to manage it in the scope of practice. We have a ways to go to get there, which is why we're all here today. But it's a reasonable expectation that we should be able to do that, particularly as medicine doctors. Any final thoughts from my team or anybody else?
I just want to thank folks who participated. I appreciate it. It'll be helpful in the future to just kind of hear different experiences, because I definitely heard today a lot of the themes that were in the slides folks have experienced. So it's good to help just get those out there and then problem solve from there.
Yeah, thank you. Thanks to everyone, and thanks again to our partners at Northwell for offering the CME. And we're excited to see folks back in 2 weeks.